So the first lecture will be given by Jean-Baptiste, approach to a failed ERCP. Jean-Baptiste, the word is yours.
Thank you, Peter. So, dear colleague, I will present you the biliary drainage in case of failed ERCP or inaccessible papilla. So here are my disclosures. So each ERCP should be the first line for bile duct obstruction. The success rate is very high, over 90%. The failure factors are surgically altered anatomy, periambulary diverticular, gastric outlet obstruction, or malignant obstruction of the lumen. So if you look to the recommendations of the ESGE from 2016, you should perform at the first line a guide wire cannulation with standard sphincterotomy. If you not succeed after 5 attempts or 5 minutes, you should prefer needle knife fistulotomy or pre-cutting. Or if you are in the pancreatic duct, you can perform a pancreatic guide wire assisted CBD cannulation or a transpancreatic biliary sphincterotomy. If you still do not succeed, you have 2 choices. Either you can repeat ERCP or consider anterograde guide wire assisted cannulation. So you have 3 alternatives. I think that surgery nobody now will ask their surgeon to operate it on. So you have in fact 2 alternatives. I mean PTBD, percutaneous transhepatic biliary drainage, or EUS biliary drainage. If we are looking to this meta-analysis from 2017 involving 9 studies, you can see that the technical success between EUS and PTBD are the same. But if you're looking to clinical success, EUS is better than PTBD, mostly in observational studies. There is more complication and more procedure numbers for PTBD. So this meta-analysis is in favor of EUS for biliary drainage. So now, which techniques to choose? You have 5 techniques. These 5 techniques that depend on inherent reason for failed conventional ERCP, the anatomic constraints, the indication for biliary drainage, and the operator preference. These 5 techniques involve location of the initial biliary access, if you have intrahepatic access or extrahepatic access, and the location of stent deployment, I mean transpapillary versus transgastric or transenteric. So hepaticogastrostomy, the first one, you will insert the wire inside the left bile tree, and then at the end you will put a stent between the left side of the liver and the gastric lumen. For choledochoduodenostomy, you will put the stent, you will insert the stent between the common bile duct and the duodenum. With the new lamps, you can do it without wire. For anterograde access, you will insert your wire through the left biliary duct, and then you will push your stent through the papilla. You have the EUS rendezvous technique. You will start with EUS. You will insert your wire inside through the papilla via the left bile duct. Then you remove your EUS scope. Then you take your duodenoscope and you will pull your wire, and you can make normal ERCP. And the last technique is EUS guided gallbladder drainage. That means that you will insert a stent between the gastric or bulb lumen to the gallbladder, and you will drain the common bile duct through the cystic. So, hepaticogastrostomy. Here you can see a very large enlargement of the left intrahepatic duct, more than 5 millimeters. You just check that there is no signal Doppler between the duct and the needle. So you release the needle access, and you make a contrast injection. So you can see there is a huge dilatation of the left bile duct, and you can see I don't know if, yeah, and you can see here, there is the tumor is here. So you will push forward your wire to be safe. You will push it. Then this is the next step with a cystotome, 6 French. You will make a perforation of the liver. So you go gently, you will push the cystotome. Then you will remove it. So you know that there is a lot of exchange, so you have to be very concentrate with your nurse when you do that kind of procedure. And then you will insert the stent through the gastric wall. So this is uncovered stent. So this is uncovered stent in the part who is inside the liver, and covered one through the wall of the gastric, of the stomach, sorry. So you will control, okay, the release of your stent, and you can see that the bile is coming. So about results of these techniques, you see that the technical success and the clinical success are very high, more than 90%, so this is excellent. The patency is between 70 and 400 days. About the safety, there are approximately 18% of complication due mainly to pain due to pneumoperitoneum or choleperitoneum and angiocolitis. Concerning choledochoduodenostomy, I will show you the case of a man with unresectable pancreatic tumor. You can see that there is this tumor, and there is in duodenoscope a duodenal stenosis that prevents you from the access to the papilla. So you can see here with a linear scope a huge enlargement of the common bile duct. You know, it's more than 20 millimeters. So first, we will perform with a hot axial system with the lamps. We first puncture with the endocup setting. You will see that we open the distal flange inside the common bile duct. And then we, as you saw Peter just before, we make a slow traction on the lamps inside the operative channel. And so we will release the proximal flange, which is open in the operative channel, and we release the stent that you can then explore to be sure is in a good position, as you can see on the CT scan. So the result, if you look at this French series or this meta-analysis of 7 studies, you see that the technical success and the clinical success is excellent, more than 95%. About safety, the complication rate is approximately around 5% in these studies, mainly due to intra-procedural complication like bleeding or dysfunction of the stent. So now, which technique use, hepaticogastrostomy or choledochoduodenostomy? I present you the result of this French meta-analysis. You can see that in terms of clinical success and technical success, you have the same for hepaticogastrostomy or choledochoduodenostomy. But if you're looking at the complication rate, there are more complications in the hepaticogastrostomy group. So this meta-analysis is more in favor of choledochoduodenostomy.
In August, he had a laparoscopic cholecystectomy with normal intraoperative cholangiography. And in September, he was admitted with recurrent pancreatitis with elevated liver tests and elevated bilirubin. And also he had right hypochondriac pain. EUS showed dilated intrahepatic and extrahepatic bile ducts, and no clear lithiasis was visualized. The pancreatic duct could not be visualized at the level of the head of the pancreas, either due to compression or inflammation. In September, ERCP was tried, but there was a failed cannulation of the common bile duct, and the pre-cut was unsafe due to insufficient washout period of anticoagulation. Ultrasound then confirmed dilated intrahepatic and extrahepatic bile ducts, and cholestasis was not resolving. So the indication for the endoscopic intervention today is in fact recurrent acute pancreatitis with right hypochondriac pain, cholestasis, and dilated bile ducts.
Thank you. Would you try to biopsy the abnormal head of the pancreas or the lymph nodes, because we still don't know the cause of the pancreatitis, or what would you suggest?
I'm not sure if there's anything to biopsy. I mean, you've shown that there's a dilation of the pancreatic duct and a minor dilation of the common bile duct, but
Yes.
I haven't really seen the area of interest yet. Maybe you have. I mean, is there a tumor? Is there
No.
an area of inflammation?
Well, I'm now going to the
yeah, maybe
D2 segment,
exactly. Maybe it's better to have a look from D2.
and well, we already had a look before we
Okay.
arrived here, and you see also lymph nodes there.
Yeah.
And how long ago is his pancreatitis?
So it's already so. Perhaps also important. So he did. I think the patient was doing well before December 2020. Then he did out of hospital arrest.
Yeah, yeah.
And get coronary stents, for which he was placed on Brilic,
Yeah.
ticagrelor. And since then he did several episodes of pancreatitis. And they did a cholecystectomy because they thought it was biliary.
So he did cholangitis 3 weeks ago. So that can also be the cause of.
Yes. So ticagrelor and ACE inhibitor. So that was also my thought, in fact.
Yeah.
But what can happen, of course, is that he had stenosis of the ampullar orifice, and then he developed this drug-induced pancreatitis, or he was more prone to develop a pancreatitis. So
Didn't the MRI didn't show evidence for pancreas divisum, and also
No,
here
no,
on
no.
the EOS, there's no signs of pancreas divisum.
But is he still jaundiced now?
He has
Yes,
a
yes.
bilirubin of 3, I think.
And it's
yes.
also recurrent.
3, that's
Yeah.
50. Okay, well then I think
We should do.
you should do something.
Yeah,
if that
yeah,
doesn't,
yeah.
We agree.
Well, I think we're still quite a long way off clinical practice like this, so outside of clinical trials, but this might change, and maybe in 10 years' time we'll be looking back at the good old days when we still did ERCP in a case like that.